Good afternoon to all the aspirants present here. It's the second class of Genito-Urinary Medicine and AIDS, and the speaker that we have here is Dr. Anand Joshi, consultant intensivist and physician at Gamman Hospital, Hyderabad. So you may take over. Thank you.
Thank you, Fatma, and welcome you all. So this is the second part of our ongoing MRCP classes for the genito-urinary infections. Yesterday, we have briefly overviewed the common genito-urinary infection, in particular gonococcal and non-gonococcal urethritis. There are quite a few there, which I recommend you guys should have a cursory overlook. This is more in terms of when you're doing history taking, you need to keep those differentials in mind. Detailing into every infection was out of scope of yesterday's talk. One of the important sexually transmitted infections worldwide, and even for that matter, wherever you are, whichever world you're practicing, is going to be retroviral disease or HIV/AIDS. Now, it is a very, very vast thing. Early, I remember my whole of my general medicine, I would say practically, I have learned on HIV patients because they are like so immunosuppressed and immunocompromised that we tend to learn lot many infections, lot many physiology, lot many pathology on these people, and it is very important topic also from exam point of view. So AIDS, acquired immunodeficiency syndrome, was first described in 1981, and then the virus causing AIDS was discovered in 1984. Since then, there has been quite a significant impact with more than 20 million deaths. More than 33 million people are living with HIV, more common still in Sub-Sahara and Africa. With the period of time and over last 20-25 years, or more than 30 years now, there has been stabilization in some regions. However, there are still few rising rates in the Eastern Europe, Central Asia. It is very sad to know statistically, or knowing the data, that almost 15-year-olds are having almost a prevalence of 33%. And these people end up dying for the various reasons, including late presentation and inappropriate treatment and therapies. A lot of social, behavioral, cultural, and political factors affect. Heart, that is highly effective antiretroviral therapy, has managed to reduce the mortality, but however, the transmission is still occurring. And to be very honest, out of all the people who are affected, only a quarter of them who need heart are on the treatment. So a lot of people have no accessibility to a treatment. We are in a very good shape. We are in, maybe India is called as developing country, but now we do have access to lot many treatment, and we are lucky in this part. But almost quarter of people who are in Sahara, Sub-Sahara desert, they don't have access to this therapy. The problem, another problem which arises with no access or no treatment, is that these people remains infectious, and for every two infections which we have, one, if even if you're treating one person of it, they have already transmitted to the people, and it is estimated that one person getting treated every time that two new infections are being transmitted. So that's a sad part. While you're giving the MRCP exam, you need to know the local data on that. In UK, per se. There has been falling death threats. However, there has been continued new infection. Now, this is something which you need to. It's surprising. If the deaths are falling, that means they are manageable. That means we cannot eradicate. At the same time, if the new infections are coming, then there is a lot of social, educational issues going on. Heterosexual and homosexual individuals from sub-Sahara are the largest affected group, and even though they are the new migrants, they do carry with them these problems. 30% of the UK diagnosis comes in the women. So again, there is something concerning from the first world country. Um, Good or bad part of it is the mortality has come down. However, we do have an aging population with HIV. Almost 25% in UK remains undiagnosed. And because of that, the presentation is many times very late. And this late diagnosis is related to the increased morbidity and the mortality. So this actually emphasizes the importance of wider testing in high prevalence areas. So even if you're in a first world country or in the UK, there will be area where there will be high prevalence statistically and epidemiologically. And then for even though patient are symptomatic, asymptomatic, it the importance of wider testing is emphasized here, because if they come late or if there is a late diagnosis, then it adds on to the mortality and morbidity. All of you know the routes of transmissions. Most common is a sexual intercourse, particularly vaginal or anal. In heterosexual transmission is the most common worldwide. Male male sex male MSM is very predominant in UK, and this is along with the sexually transmitted infection. So those people who are victim, or those who are already having the sexually transmitted infections, these people are at the increased risk of transmitting the HIV. The second mode of transmission is mother to child, that is a vertical transmission, and that happens through either a transplacental or at the time of birth or with the breastfeeding. Now, almost 15 to 40% of the babies affected without intervention, 15 to 40% of the babies without intervention, it's affected through transplacental infection. And these transplacental infections are associated with advanced disease in mother, high maternal viral load, prolonged labor, and premature rupture of membrane and chorioamnionitis. Along with that, if the mother is breastfeeding, then it doubles the risk of transmissions. However, like these things are more common and known when there is no intervention. But the intervention with the current guidelines and the proper use of antiretroviral agents and avoidance of breastfeeding has been effective in the developed countries, including UK, and the numbers of and the number of babies with active HIV infections are falling down. Other routes of transmission is with the contaminated blood and blood products. Now, with the new screening laws which has been implemented across the world, these incidents are coming down. However, still, even in a small percentage, these routes are still prevalent. IV drug use, needle stick injuries are another common. Healthcare workers, we are at very risk, and with the proper implementation, though, the risk has come down to 0.3%. It is important for us to know and to educate our surrounding and those who are non-medicos, and let them know that there is no spread through social contact or insects bite or the mosquito bite or blood sucking insect, or use or sharing of the things, glass, or having food in the same thing, same plate. These things do not transmit the HIV. There are a lot of misconception, and hence I have to emphasize on it. Now let's look at the virus. So it's a Retroviridae family, lentivirus group. There are two main viruses known, HIV-1 and HIV-2. HIV-1 is more virulent and widespread globally, and HIV-2 is there mainly in West Africa. Now, if you remember this, or if you try to kind of keep it in your back of your mind, this structure, it becomes very easy for you to understand the antiretroviral therapies and where do they act, etc. So you can see this is a like any virus, you can imagine it like a cricket ball kind of thing, and this whole outer cover is made up of lipopolysaccharide or lipid layer. In between the lipid layer, those mushrooming like things which are coming, the green and the top, they are GP41 and GP120 proteins. Together, they are called as 100 and GP160. These form the envelope. Now, inside the lining is P17 matrix, and inside that, the pink color with surrounding beads is the core. Now, this core has a single stranded RNA, and the green color which has is a reverse transcriptase. Now, this is a very important enzyme because this is the one which embeds, or because of this enzyme, the RNA gets into a DNA, and then that DNA gets embedded into the human DNA genome. So this becomes an important target for the therapy. The small blue ball are the proteases. They are responsible for reforming this outer cover and other protein components, and they also become an important target for treatment. Please, anybody having any questions, please stop and ask. We'll appreciate that. Now, with advancement in the science, we have now known, and we will be focusing or talking mainly on the HIV-1. So HIV-1, there has been a lot of genetic diversity. Now, why we need to know the genetic diversity? Because many a times some targeted therapies may not work, or suddenly may stop working, in which case you may have to look into the genetic group. The most common and the most major group is M group, and then you have NOP. They have further subtypes from A to K. It forms in the recirculating recombinant forms, CRFs, and subtype B is more common in Europe and North Africa. Then other groups, we have group N, most commonly in the West Central Africa. Then we have group O, which more in Cameroon, and then we have a group P. Now, how does this HIV enters into the body and cause the disease or cause the AIDS? So entry is enters the body, and it enters the immune system, particularly targets the CD4 plus T cells. And these CD4 T cells have got CCR5 co-receptor, which I will show you in the next figure. Early infection occurs in the gut, and as we know, the whole gut wall has got a lot of submucosal lymphoid tissue, and it attacks and starts destroying the CD4 cells, and that's when it depletes the immunity at the gut, and that's why their presentation with like abdominal pain and diarrhea. The virus per se has a half life of about 6 hours, and however, once it enters into the cell, the multiple virus keeps on multiplying and getting produced more and more, and then it literally bursts opens the CD4 count, causing the cell death, that is CD4 cell death, and then release of lot many viruses, which will again go further and look for other CD4 cells and enter into their cells. The viral turnover is very high, almost 10 raised to 8 to 10 raised to 9 viruses per day. And this leads this rapid destruction of the CD4 cells and acquiring of the new CD4 cells, and then again destroying them, leads to their depletion and hence the immune dysfunction. So this is the pictures presentation of what I said. So as you see here on the one, you have this HIV virus with GP120 and GP41, which binds to the CD4 receptor of the lymphocyte. Along with that, there are also co-receptors, which we talked about, like CCR5. Now, why we need to know about the co-receptor? Because again, it becomes a therapeutic target for the treatment. So once this outer envelope gets attached, these receptors get fused with the outer wall and releases the core. And as it releases the core, it opens up, and the RNA gets released into the cytoplasm. Now, this mRNA, in the presence of the reverse transcriptase, get into a DS double-stranded DNA. Copies are formed from the RNA template, which again gets embedded inside the human DNA. This human DNA, as we have mitosis, meiosis going on, as it gets divided, that we call it as a transcription, it causes further release of mRNA and mRNA genomes. Now, this mRNA, with remember, we have those protease, which are the proteins or the enzymes sitting inside the virus. These protease, along with the other structured proteins, with the help of reverse transcriptase, again leads to the formation of the viruses. So this viral capsid assembly, so the inner core is formed, and as this inner core forms and it buds out through the lymphocyte, and this is called as budding, and the virions are released. These virions gets matured and then again enters into the new cells. So this is why we need to know this, is because this 1, 2, 3, 4, and 5, which you are looking at the screen, are the 6 are the potential therapeutic targets, and hence you need to know. So if you know these things, you know where the things are happening. Now, that was what the virus does to the body. And with that, as the CD4 tells, and as with any other virus, it stimulates the immunity. Now, immunity has an on switch and off switch. It gets on switch when the virus is entered. But here, the virus is making house inside the immune cells, CD4 plus cells. And then it bursts open and keeps circulating and stimulating the immunity. So a state of chronic inflammation gets established in the body. And this interaction causes this chronic inflammatory state. And chronic inflammation now occurs from HIV per se. Now, along with this, as the immunity goes up and down, or rather declines, other opportunistic infections starts bothering, especially the CMV and all the gut translocating bacteria. So all these things when they enter into our immune system and with their lipopolysaccharide and their pro-inflammatory stimulation or triggers, this keeps the body in a perpetual state of inflammation. And this resultant cytokine release and the cytokine dysregulation plays an important role in the end organ damage. So you can say that what happened, why does the patient, if the patient doesn't get secondary infection, assuming the patient is in extremely sterile case and have no secondary infection, will the patient die? Yes, he will die because there is a perpetual inflammation going on, perpetual cytokine things are going on. We normally see these things in the intensive care in acute phase where there is a large cytokine release and then the patient gets into that end organ damage, and then we call it as a sepsis induced multi-organ dysfunction. The similar thing happens, but it happens in a slow motion here. The cytokines are released and there is a continuous immunity stimulation, and then there is again the systemic inflammatory response, and then it has a counter regulatory, and this circle goes on and ends up in a end organ damage. Not to forget, during this all this chronic inflammation going on, opportunistic inflammation again come and again stimulate the other way around. So it becomes now very important to diagnose and understand the natural history, which we just now talked. As against what we had about 30 years back or 35 years back, now HIV has become chronic but manageable disease if they are diagnosed and treated early. Even today, if the diagnosis is late, then the person chances of dying is very high. More than 50%, even in UK, are diagnosed in the late, especially when the CD4 count have fallen down below 350. And this highlights the importance of HIV testing strategies. So what are the current HIV testing strategies? So current recommendation, we use the use of fourth generation test, that is an antibody to HIV virus and P24 antigen. Now, even with this requires a 4 weeks of window period from infection to positive ELISA. So at least a month remains. So why this is important to know, that if the test is negative and you're highly suspecting, then you'll have to repeat it. So it's approximately 4 weeks of the window period. There are other different tests where we have screening with ELISA, enzyme-linked immunosorbent test. It's a technique where we screen for the IgG antibody to the envelope. It usually becomes positive after 3 months. Other rapid tests are also been developed with blood oral fluids. However, they are called as those spot tests. However, they have a very high false positive result. So if you get a rapid test positive, then all these reactive tests require a confirmation with a Western blot, which is very specific. Other targets where we can detect the HIV infection is the P24 antigen, which is detectable immediately after infection. So if you have access to P24 antigen, which we have seen previously, then it's a very good test. Trying to use this test later may not be helpful because it disappears within 8 to 10 weeks. Antibody to P24, again, it's an early in the infection, and when the patient is asymptomatic phase, you can detect it. This gets lost as the disease progress. Because there are multiple tests available and their positivity is variable, so there is an algorithmic approach has been developed. They call it as a STARS. This is especially true for pregnancy, perinatal people. This is a serological testing algorithm for recent HIV seroconversion. So, what do we do in this? So we do two tests here. One is an highly sensitive ELISA, which detects the HIV antibodies, and we can safely say that the patient had HIV antibody between last 6 to 8 weeks. And then we also do a less sensitive test, detune test, which identifies the infection for less than 130 days. So we can say whether there has been a recent infection and a seroconversion or not. So if it's a first one is positive and second one is negative, then we can say it was a recent seroconversion. If both are positive, then probably this is not a recent seroconversion step. Further to that, there are few other tests like nucleic acid amplification test, that is NAT, and isolation of the viruses. And this is more for research and epidemiological purposes. In UK, as we have seen, because almost 25% of them are remain undiagnosed, a lot of people present when in a late diagnostic stage. Universal testing guidelines have been proposed, and this is for the UK. Every country has its own things. US has a different, UK has a different. More or less, they are all same. One is universal a universal indication for doing an HIV testing. So these are for all sexual health clinic, antenatal services, termination of the pregnancy services, again, drugs and drug abuse programs, and in UK, healthcare services for tuberculosis, hepatitis C, and lymphoma. So all these people, all these clinics need to have the HIV testing because these are all associated more or less with the AIDS. People in whom the HIV testing is recommended, again, all the patients diagnosed with sexually transmitted infection, their sex partners, men who have disclosed sexual contact with other men, female sexual partners, IV drug users, known from the country with high HIV prevalence, um, those women who report sexual contact abroad for the recreational thing they have come in, or those are presenting for the healthcare. So if you're going to work in a healthcare setting, if you're a doctor, nurse, then again it became a mandatory. There are few HIV associated indicators with every system having a particular disease that again warrants that these people should be screened for HIV. And that goes from respiratory tuberculosis, aspergillosis to almost everything. Dermatological, gastroenterological, we have a diarrhea, hepatitis B infection, oncology, gynecology. The list is long. So let's look at the clinical spectrum of HIV. Now, once the HIV person gets infected with HIV, the clinical spectrum or the presentation is due to either direct viral effect that we call the primary HIV infection or PHI, or immune dysfunction and opportunistic infection with which the patient will present, or the co-infection, particularly sexually transmitted infection, or the presentation within a known case would be a treatment side effect. So this is the spectrum where the patient will be presenting. However, for initial diagnosis of AIDS or HIV classification, CDC has given in 1993, and that seems to be continued even today. These are like categorized based on the CD4 count, that is A, B, and C. A would be the asymptomatic, and C remains as a AIDS defining diseases. Now, B is the one which is not in A or not in C. Now, this is classification 123, 123, 123 is based on the CD count at 500, 200 to 500 and less than 200. In category B, we have an examples where HIV related conditions. You should have bacillary angiomatosis or candidiasis or other constitutional symptom, oral hairy cell leukoplakia. All those things will come under B category. What are the age defining conditions which we saw in this C? So this is the list, which includes mainly the immuno opportunistic infections or the infection commonly found in immunosuppressed people. So we have candidiasis, we have cervical carcinoma, we have cytomegaloviruses, retinitis, encephalopathy, if you're suspecting HIV related. Then you have Kaposi sarcoma, your histoplasmocytes, lymphomas, atypical mycobacteria, PJP pneumonia. All these things, if you come under a age-defining conditions, AIDS-defining conditions. So how would you define the AIDS? Now, USA, America defines the AIDS as anybody with CD4 count less than 200 plus indicator conditions, then it's AIDS. Whereas in Europe, CD4 counts are not given so much of stress and it is just based on the clinical condition alone. Irrespective of that, because of highly active retroviral therapy, the progression of the HIV infection to AIDS have significantly come down. So you may see the mixed picture. Again, remember, HIV infection is different from the AIDS because AIDS is more of a clinical thing, and HIV can come as a asymptomatic. So when we look at the clinical spectrum and when we talk about the primary HIV infection, usually you see that after getting infected, up to 6 months, you is considered as a primary HIV infection. During these 6 months, the viral load is extremely high at this moment, and hence the high risk of transmission is there. Usually the first 2 to 4 weeks are clinically and serologically silent. So that becomes very important. The patient may not be feeling anything or just very simple constitutional symptoms, which are very mild. And even when you do test them, these people for during this time, they are serologically silent. Somewhere between 3 to 6 weeks, the constitutional symptoms occur on just 50% of the cases. It includes fever, rash, some lymphadenopathy, headache. Rarely the neurological symptoms are very severe where you have myelopathy and encephalopathy. All these things may go away without any treatment, and the recovery with the standard supportive care may occur within 3 weeks. During this time, there will be a lymphopenia with reactive lymphocytosis. Some will have thrombocytopenia, deranged LFT. CD4 are quite significantly depleted. Now, we don't usually ask for a CD4 count, but this is something you have to keep in the back of the mind, or at least CD4 CD8 ratio, which gets reversed. Antibody is absent. However, as described earlier, if you look specifically for antigen, then it might get detected. For epidemiological purposes, and if you have an access to nucleic acid amplification, then the NAT for HIV RNA becomes diagnosed in first 7 days. But however, the standard antigen and antibodies are negative. So once this get infected, how does the HIV affects all the organ systems? So neurologically, it invades nervous tissue early, and as the disease progress, the symptoms also increase. Key defining conditions are ADC, that's called as AIDS dementia complex, sensory and autonomic neuropathy, and aseptic meningitis. The ADC presents as a memory loss, poor concentration, psychomotor slowing, mood and changes in behavior. MRI would show a classical white matter T2 lesions with EEG showing encephalopathy sign. However, CSF would be normal. Sometimes when if there is an aseptic meningitis, you might get a little bit of increase in the protein, but otherwise everything else remains normal. Ocular manifestations would be, we are going from top to bottom. So ocular manifestations would be, but is typically seen in a very late stage of HIV, HIV per se. And the most dreaded and sight threatening is the CMV retinitis. If you do a fundal examination, sometimes you may get with cotton wool spots or anterior uveitis. That will be primarily because of the HIV. Otherwise, you may see in eyes the opportunistic infections that like toxoplasma, syphilis, lymphoma, and excuse me, uh, pneumocystis. Mucocutaneous manifestations, usually because of the disrupted Langerhans and dendritic cell functions. You'll get these pruritus, dry skin, eruptions, eosinophilic folliculitis. Patient may have, if they are already on heart or any HIV related drugs, then they may have drug-induced rashes, commonly with the sulfa, and opportunistic infections from the skin infection and after ulcers. So this is just a list of disease you can get, abnormalities you can get from on skin and the mucous membrane. We got from dryness to tinea to warts to the herpes, scabies, Kaposi sarcoma. In mucous membrane, you may have oral and vulvovaginal candidiasis, aphthous ulcers, again, herpes simplex, periodontal disease, and warts. Hematologically, you may see complications includes progress to lymphopenia and neutropenia. Thrombocytopenia can be an early manifestation. Now, it can be because of the antiplatelet antibodies or in impaired bone marrow production. Pancytopenia is commonly seen if there has been opportunistic infections or malignancies, or they can be hematological complications secondary to the drugs of the use drug-induced from the heart or from the treatment of opportunistic infection, like particularly cotrimoxazole. The gastrointestinal effects, the common because the lymphoid submucosal lymphoid things are throughout the gastrointestinal tract and they get affected. So chronic diarrhea is common, associated weight loss. We call it as a HIV enteropathy. Again, same opportunistic infections, protozoals, and other spirochetes. They all cause poor absorption. Now, rectal lymphoid tissue acts as a viral reservoir, which is very, very important. There is a lot of viruses that stay in the rectal lymphoid, and hence it's easy transmission for the unnatural sexual activity. HIV-associated nephropathy, called as HIVAN, is quite known. Commonly found in the black males. Pathologically, there is a focal segmental glomerulosclerosis mimicking, leading to nephrotic syndrome. Other renal complication may occur because of nephrotoxic drugs, which are commonly used to treat the opportunistic infection in HIV, and we have to be careful of that. Respiratory complications would be the increased infection from the airway and mucosal damage, chronic sinusitis, and lymphoid interstitial pneumonitis, which commonly seen in the pediatric cases, and they are usually steroid responsive. Endocrine complications we have seen can present as adrenal insufficiency, especially with infection, hypogonadism, and CMV-linked adrenal failure. The cardiovascular complications reported are the cardiomyopathy, myocarditis, causing heart failure, ARV-related lipid changes. In one of epidemiological study, which is called a SMART study, there was a correlation of ischemic heart disease with intermittent uh, this acute retroviral disease therapy. Sorry, not like intermittent retroviral disease therapy. The other clinical spectrum further would be vast, practically anything under the sun, immunodeficiency and opportunistic infection, and this happens particularly when the CD4 count starts falling. So more or less, lower the CD4 count, higher the susceptibility to the vast range of organisms which are there on the earth. Again, it becomes extremely difficult to diagnose because once the CD4 count and your immunity is down, your appropriate SIRS response is not there. So these infections essentially enter into your body without any resistance. And addition to that, because the immunity is so low, multiple infection together is possibility. So this is just a list of major HIV-associated pathogens where we have a toxoplasmosis and cryptosporidium, and then we have viruses, CMV, herpes. Then we have fungi like PJP, Cryptococcus, and all the usual list of bacteria. So how would you manage these patients? So management of an HIV infected patient is quite a vast topic again. What we'll be talking mainly is HIV per se, and not the infection associated in this talk. So management of HIV involves one, starting of antiretroviral therapy. And now, because it is very toxic, we need to monitor one, its effectiveness and its side effect. And we also need to monitor the resistance, if at all it's developing, and the drug-drug interaction that it can cause, and which are also again very important while you are treating a complex HIV patient with multiple infections or opportunistic infections. The goals of ART, so when you're using your highly effective antiretroviral therapy or heart therapy, is to suppress viral replication. So the viral copy should be low. You need to have those CD4 count coming back, that is restore and preserve immune function. And this will lead to reduced HIV related morbidity and mortality. And importantly, try to prevent the HIV transmission. So lower the viral load and higher the CD4 count, then the chances of HIV transmission again goes down. So how will you approach an asymptomatic patient? So whenever you come across in a screening that the patient has got HIV and his antibody or antigen is positive, however, the patient is asymptomatic. Now, the guideline says that when you encounter these patients, they should be within 2 weeks seen by a specialist. And when it comes to you as say, if you're a general practitioner, then you should be regularly, approximate 3 monthly, assess the progress, if the patient is on treatment or whether the patient is not on treatment. And when as I will mention it later, when the appropriate time comes, you have to take the decision to what kind of intervention you have to do. A general guideline for the patients who are newly diagnosed and asymptomatic, you should have this list already ready with you. One is the hematological counts, biochemistry, including vitamin D because of the complications of osteoporosis later, urine analysis, and looking for the other sexually transmitted infections. Immunologically, in UK particularly, this HLA-B5701 status is gene is need to be asked for, because one of the drug abacavir has a fatal interaction or has a fatal side effect uh, for these people, so that needs to be avoided. Otherwise, when it comes to the virology, you need to have this HIV antibody confirmatory test. You need to have the viral load, and also look for the other hepatitis viruses, hepatitis B, C, and you'll be surprised how commonly they are associated and they have a co-infection. If depending upon the clinical situation, if it demands, then you should look for toxoplasma serology, syphilis serology, and few other X-rays. How will you monitor an asymptomatic patient? So you need to have an immunological monitoring and a viral load monitoring, and if possible, go for a genotype determination. So for immunological monitoring, you have a CD4 count. It's performed every 3 monthly. For viral load, HIV RNA is what you need to look for. Now, branch chain DNA is what you see. RT-PCR is very popular, and nucleic acid sequence based amplification. So whichever one is available, you should go for it. Usually, the results which you get will be the viral copies per ml of plasma. Now, copies more than 10 raised to 5 has a 10 times high risk of progress to AIDS in 5 years as compared to 10 raised to 4. So it is that bad. Just a 10 times high, 10 raised to 5 will suddenly increase the chances of having bad prognosis. So the third one, genotype determination, if you have access, you should do it. And this is mainly be helpful for the drug resistance. This is the brief picture which will give an idea about the time interval where people will be asymptomatic, or they may have a little bit of the symptoms. After the initial couple of weeks, when you have an CD4 count remains high, so a lot of people remain stable. So they may not progress to AIDS, and that time has been given quite a wide, from 6 weeks to 10 years. The viral load may remain low and the CD4 count may remain high. However, on an average, by end of 10 years, the thing starts plummeting plummeting in the opposite direction, and then they may rapidly deteriorate. So these people need to be constantly follow up, even though they are asymptomatic, and looked for CD4 count and viral load. As long as viral load is low or negligible, or CD4 count is high, you are still okay. And this is for the patient who is asymptomatic and not on yet started on the therapy. Once these things starts coming down, CD4 counts and viral load going up, so that is where the seroconversion, we'll talk about it, the seroconversion therapy. Introduction of the antiretroviral therapy is important, and that's where you win upon for the better management and control, and prevent the morbidity and mortality. So that was for the asymptomatic patients. What would you do if there is a sick HIV patient? And it is when you get to a sick HIV patient, then the thing, it's completely different ball game. One, never try to manage it in single-handedly. It has to be a multidisciplinary approach. Now, depending upon what stage you are seeing, whether that sickness is bad enough to put the patient in ICU, or whether he is sick enough presenting to you with the various symptoms, you need to understand the psychosocial support which is surrounding him. Because once you start, and with the multidiscipline, it's going to be a long haul, and adherence to the treatment becomes very important. Also, do not forget that non-HIV related pathology can also present in a HIV patient. So sometimes not everything is should be dumped onto the HIV or HIV related. So basically, you have to keep your spectrum and the differential broad. Now, when you're approaching these sick HIV positive patients, the potential problems you would come across, that is this an adverse drug reaction for the patient who was already on HIV drugs and been started on some other medication, or whether this is a new acute opportunistic infection, or whether this is an immune reconstitution phenomena, or this is an infection in immunocompromised host, whether it's an organic or functional brain disorder. You will be surprised when everything is going fine, and why you feel that this person is having this encephalopathy or catatonic posturing. It might be a psychological depression. Again, non-HIV related pathology need to be kept in mind. A full medical history needs to be taken, and remember to take a detailed, very, very, very detailed history of antiretroviral drugs, how much prophylaxis, when it travels, any previous HIV related pathology. Uh, Hunt for potential source of infection, food, pets, acute infection, contact with TB, sexual activity being continued, and all these things will not come out unless you are ensuring and securing confidentiality in the patient. Also remember to do a complete detailed physical examination. Look for the small clues: skin, nails, oral cavity, eyes, genitalia, retraction. Look for the genito-urinary things, and try to look for all the rashes, all the clinical evidence of immunosuppressions, um, and look for lymphadenopathy. Investigate, try to investigate as thorough as possible. Besides the routine, look for the microscopy, cultures, serologic, depending upon the clinical suspicion. Look for the serological testing for, say, cryptococcal, toxoplasma, and of course CT, chest X-ray, and if required, don't hesitate to get a CT or MRI done. So while you have done, and you now decide to start the patient on antiretroviral therapy, just a quick look at the classes of antiretroviral drugs which we are available. Now we've got this six broad categories, out of which the NRT and NRTIs are one of the very, very old generation ones, but they are still are very relevant. Then came the protease inhibitors. The near recently, I won't say a very latest one, but near recent are these NCTs and co-receptor blocker and fusion inhibitors. Just a quick look on NRTIs, and I would recommend, because this is just a presentation, I am going to just go and have an overview, but I would recommend you guys to have a detailed read at least once of each and every medications. It once in a lifetime you should at least have a detailed reading for these drugs. So NRTIs, especially the tenofovir, abacavir, zidovudine, lamivudine, they have their side effects. So like tuberculosis, anti-HIV drugs are also known for more for their side effects rather than effects. So you have tenofovir, then you have which has got a renal and perhaps cause bone dysfunction. Then HLA-B5701 associated abacavir hypersensitivity reaction. We spoke about it. Then lipodystrophy with the zidovudine and stavivudine are known. Then again, and then RTIs, they have their own toxicities like a CNS toxicity, teratogenic potentials, hepatotoxicity. Hence, they are usually not preferred in females who with childbearing age group. And we have integrase inhibitors. There is no short-term or long-term known toxic. They are relatively safe. Then we have protease inhibitors. The one of the big thing about it is that it is extensively metabolized by P450 enzyme. So any enzyme inducers or enzyme suppressors would have its effect in the blood levels. Then we have CCR5 inhibitors. It's only active in patients who do not have viron that uses CXCR4 for cell entry. So again, this is a drug which will require genetic diversity or genetic testing for the virus. Then we have fusion inhibitors. It's an injectable given subcutaneously twice daily, so that becomes a problem for some people. How do you initiate? Usually, the preferred regime is 2 NRTIs and 1 NCTs. That is now the current preference. However, this has to be tailored with a different patient. Initiate ART in all HIV positive individuals who are meeting the criteria, and consider the patient specific factors like comorbidities, drug interaction, and adherence potential. So when you're starting antiretroviral, when you're treating a primary HIV infection, a treatment in the clinical trial, or if it's in a neurological involvement, or if it's a CD4 count less than 200 for more than 3 months, or if the AIDS defining illness are there, then you should start the patient on the antiretroviral therapy. If it's an established HIV infection, less than 250, treat. Between 250 to 350, see how the patient's adherence, compliance is there, because it's no point in starting. Adherence plays a very big role because a lot of patients will leave. What we have seen in tuberculosis in India, they won't take properly and then develop resistance. So again, the patient education, and because they are in the gray zone, you can't even actually push. Those who are on more than 350, it's only if we are looking at enrolling in some kind of trial or new drug trial or some kind of study, then you can enroll them and start them on ART. But try to avoid. It's no harm if you don't give it. Alternatively, if the patient has already got AIDS defining conditions or CDC stage C, then you have to treat it. Unless the patient has got tuberculosis, then in that case, you have to wait for the CD4 count to go up more than 350, and then only treat with HIV antiretroviral therapy. As I said, NRTI or NNRTI preferred is tenofovir, emtricitabine. You can use alternative abacavir and lamivudine based therapy. And the third agent you would put in will be any of the one which is listed. Once you have started, how will you monitor? So once you have started, you need to monitor with the viral load and CD4 plus counts. So you have to take a baseline after 8 weeks and every 3 to 6 months. Now, by end of 6 to 12 weeks, not by end of say 12 weeks, the drop should be at least it should have the viral load should have come down below 50 copies per ml. If that is not happening, then you should get alarmed and start looking for any reason, including adherence or compliance, to see why this is a suboptimal dose, because theoretically the viral load should come down. Same is not true for CD4 count. CD4 count remains variable and it may go up and down, but the treatment therapy response for the viral load is very, very important. If even after 12 weeks or even after ticking all the boxes, you are not finding there is a suboptimal response, and if the viral load remains more than 200, then look for the resistance to the drug. That is very important. Along with this, also monitor for the drug toxicity with bone marrow suppression, liver and renal failure. So this is the list of the things which you should monitor a patient on heart: clinical history, same physical examination, and additional investigation, particularly HIV genotype if there is evidence of virological failure. If you suspect CRT, ART resistance and failure of treatment, then look for what would be the cause. Most commonly, it's not the drug; it is the poor adherence. Later, you can look for any drug-drug interaction. You have introduced some statins or CYP 450 inhibitors or inducers. Those things you have to search. So the patient has not told you, has gone to some other doctor and he has taken up some medications, and it becomes a challenge. Start suspecting if the patient has got resistance or failure when everything was going fine and suddenly your viral load starts going up and CD4 starts going down. It will be very reasonable to perform a genotype resistant testing in this kind of thing. And then once you have gone through all the checklist, you can modify the regime based on the resistance profile. When you're evaluating the resistance, look for the different mechanisms. So HIV replicates rapidly and uh, inaccurately. I mean, it's not exact copy. So that is again a flaw of HIV virus itself, and which can be partly disadvantage to us, because if we know exactly how the HIV is replicating, then we can formulate the drugs to attack. But if it's randomly replicating in the process, then sometimes we may not be able to attack those viruses, and those viruses may bypass the treatment and hence the resistance. Then sometimes there is a point mutation that can occur. Then you also look at whether the antiretroviral drug adequate blood levels are achieved, whether the patient is taking regularly all the treatment or not. Then some ARVs, especially NNRTI, have low genetic barrier. That is, small number of mutation can also cause a resistance. Sometimes the patient would randomly stop the drugs, and then they may take it in a very irregular way. So the subtherapeutic drug levels may induce the resistance. Again, we spoke about the impact of other concomitant medications that can impact cytochrome 450, may also lead to drug resistance. In these cases, therapeutic drug monitoring will also be useful, especially if we are suspecting any subtherapeutic levels of the medications. We have already covered this, the drug interactions and its toxicity. Importance of adherence and counseling for the adherence cannot be more emphasized. And we have seen this, especially with our tuberculosis. Exactly the same thing remains. Providing an education, psychosocial support is important here. So you are treating a patient with HIV with some therapy, some specific combination of the therapy. When would you change the therapy, or what are the situations where you look forward to changing therapy instead of stopping the therapy? So when you are reviewing the treatment. If the viral load is going up, the CD4 starts falling down, there is a new clinical event suggestive of HIV, and you have looked for the cause of treatment failure or mechanism of resistance, both clinical and non-clinical, then these are the things, time when you need to change the therapy. There is also something called as virological failure. So when two consecutive viral loads are more than 400 copies in a previously fully suppressed patient. So previously the patient was very good, his viral loads were very low, less than 50 copies, and now you have one instance where it has gone up to 400 copies, and then the second one again still remains above 400 with the same treatment. Then these are the situations where you look for the changing of the therapy. So when you change the therapy, you should introduce completely a new class of drug. Don't just change the therapy or a treatment in the same class of drug. So because they probably have already developed a resistance on that. So try to change completely new class. And suppose if you are following up a routine following up and you are not worried about anything, everything is going fine. However, the patient comes and complains, which you think that is a side effect of the drug, then don't change the whole class of the drug. You can just change uh, the drug in the same class, because here you are not changing because of the some treatment failure or resistance, but you are changing because of the side effect, to avoid the side effect. So different drug of the same class can be used in these cases. Under what circumstances you should stop therapy? See, theoretically, you should not be stopping therapy, and therapy is a lifelong. However, there are certain compelling situations. None of the current guidelines support any kind of even interruption, that stopping, starting, stopping. No, unless you are looking at some kind of cumulative toxicities happening. There is a renal failure, liver failure, some drug-drug interaction has happened, or the patient, despite a lot of counseling, is so poorly adherent. So it is better to stop. Don't give him. Leave him alone. It's no point in going behind him. Or the quality of life is so poor that even giving him this medication and controlling in HIV is, we are not going to contribute anything. It's almost like a end of life care decisions. So when you're stopping the therapy, remember that NNRT has a very long half-life, and they should be stopped first, and their effect can still continue to linger. So while we are looking at an effective antiretroviral therapy, as I said, they are more notorious, like an anti-tuberculosis drug, for its side effects rather than effects. As I said, heart has transformed HIV into manageable conditions, and however, side effects and complications are common. One is an allergic reaction. We have spoken about this. Abacavir hypersensitivity is very well known, especially linked with this gene. The thing here is that if you are suspecting it, do not re-challenge. If you try to re-challenge to give the drug to the patient once who had a bit of a reaction, it can be fatal. The second one is with the NNRTIs, which are probably a maculopapular fever and some liver dysfunction, and that can be managed with a standard supportive medications. You need not stop that for and if only if the supportive medicines are not helping, then only you can stop or change. Lipodystrophy and metabolic syndrome, which is quite annoying. It may not be life threatening, but there is a loss of fat in the limbs and the face. And then there is a lipohypertrophy in abdomen and the breast, and it becomes just disfigurement. It may lead to some insulin resistance also. And this is particularly seen in NRTIs and PIs. Management is simple: diet, exercise, statins, and tesamorelin. That is an FDA approved drug that may help. Mitochondrial toxicity and lactic acidosis are another one. Especially if the patient is in ICU, very sick, then those on stavudine or didenosine will have a high iron gap metabolic acidosis, for which we have to immediately cease it. It's not good. Osteopenia, osteoporosis are also the side effects. Monitoring bone health and considering supplements, vitamin, calcium, and vitamin D, and a lifestyle is recommended. This is something which everyone should be aware, and you may also see this in your tuberculosis patients. This is called as immune reconstitution inflammatory syndrome. When a patient is very, very severely immunosuppressed, the CD4 count in the boots, and then the viral load is high, and suppose there is a secondary infection. Because the immunity is so low, there won't be any SIRS response, no fever, no high white cell counts, or any of those things. But if these patients are treated with heart, and if you start the heart, then the CD4 count starts going up. The viral load comes down. And once the CD4 counts reach to a reasonable level, they will induce an inflammatory response. And then we may think that the patient has deteriorated. No, actually, it is not deterioration. It is actually the inflammatory response which gets manifested. This is classically seen that the TB patients gets flared, or CMV retinitis, or they get into hepatitis. Here, it requires a proper understanding and a symptomatic and management. And don't try to completely cease the ART. This is an immune constitution. Steroids are good in these situations, and they will try to decrease the inflammatory response. A few word about special situations, that is the acute seroconversion. Now, I have shown you the previously one slide where from 6 to 10 years, 6 weeks to 10 years, the patient remains steady. Now, at what point this patient will drop his CD4 count along with increasing the viral load, we don't know. There is no mathematical formula. There is no exactly the timeline, and the timeline given is from 6 years to 10 years, 6 weeks to 10 years. So which is quite a ridiculous time zone. So when this happens, this patient, we call it as an acute seroconversion. And to be very honest, whether to start the therapy at this point, like for example, the patient comes with a constitutional symptoms, but the CD4 is still more than 350, viral load is not that high. Whether to start or not, it's a controversial. Pros: if you start, then you are actually suppressing the viruses, and it's preventing from multiplying, and also you are preventing the immune system from getting degraded, and protecting the CD4 count. Whether that helps in future prevention of preventing AIDS formation or not, we don't know. So this is a very unclear thing, and there are still trials going on. So best when you encounter this kind of situation, it is better to have a second opinion with a specialist, other specialist, who is more involved in managing the HIV patients. Pregnancy again becomes tricky. Here, the aim is to not only to protect mother, but also try to prevent the vertical transmission. Now, there has been various regimes. Triple therapy is preferred now. There are few drugs like efference is avoided in the pregnancy because of the birth defect. There is another different regimes. Out of one of the regimes, Zidovudine is used for the for the infant in a postpartum. Post delivery, there should not be any breastfeeding, as we have seen breastfeeding transmission almost doubles. Um, it's not necessary that all the patients should undergo C-sections. If the viral load is very well suppressed and the mother has is well maintained with the heart previously, then a normal vaginal delivery is also possible. Post-exposure prophylaxis, very important. Every healthcare worker should be aware of it. The person should receive within 72 hours. In UK, there is a standard recommended regime, that is Truvada and Caletra. These are the combination of the triple drugs with the brand name. You have to monitor for toxicity. However, even this post-exposure prophylaxis we are there, it's not still 100% guarantee that you will not get you will not progress to HIV, or in viral replication will not go up in your body and you will not get AIDS, nothing like that. So there will be still be some chance. So the reason I'm saying this, that this is just because you know that there is a post exposure prophylaxis, this is not a replacement for safer practice. Okay, you also take all the universal precaution. Right, so it's 1 hour 20 minutes. There is still a lot. There are opportunistic infections, there are specific infections, and malignancy associated with HIV is there. I felt that I have just covered the current epidemiology. I have covered the pathogenesis, the clinical features, and the HIV per se as a core topic. Now, if it will, this the rest of the opportunistic infection, specific infection, and malignancy will further take 1 to 2 hours. But I wanted to stop it today here, and would like to get a feedback, whether you're okay to stop here or you need this opportunistic specific infection malignancy, and that has to be covered in the sometime in the next sessions. So I will talk to Fatma and the coordinator to see if we can accommodate one more session for this. Any questions before we stop? Any questions for the current topic? No questions? You can put it in the chat.
If any aspirants have any question, you can ask right now, or you can write it in the chat box, or can unmute your mics.
Yeah, Manoranjan.
Sir, I believe for now they do not have any questions. So, sir,
Okay.
if anything arises, we'll be scheduling the classes again.
Okay. Now we still have quite a few things to be covered, Fatma. So if you can just discuss with the management and let me know, we will reschedule or we will have to schedule another 1 more hour for it, because the topic is extremely vast.
Sure,
So
sir.
it was this only took 1.5 hours to go,
Yes,
and
sir.
I don't know how
Okay.
many people are still awake. Most of them might have got asleep.
Okay, sir.
Okay.
Okay,
All
sir.
right.
Thank you, sir.
Thank you very much.